Hello and welcome to this webinar hosted by Pallium Canada. This is one in a series of webinars that we've been doing over the last few weeks and will continue to be doing in the weeks to come and months to come around palliative care and specifically around the palliative response to the COVID pandemic. Today's topic is on providing virtual palliative care. And I think fairly early, when I say early, in early March, there were colleagues across the country, across all different sectors of care, from palliative care to primary care, identifying the need to support patients virtually. And we were hearing that from countries like Italy and Spain and the United States. And so many of our colleagues and folks across the country started doing that. And so there's been an experience base being built up on that. And we thought it would be very timely to share experiences. But we also think it's important to look back because virtual care is not something new to palliative care. It's been happening. And so today we're going to be hearing some of those experiences. And the whole goal of this is moving forward that we leverage this technology well, judiciously, and effectively, that we understand its strengths and its limitations. We know when to apply it, and we know when to resort to the old and ongoing and still very, very pertinent way of caring, and that is hands-on caring. We've got a fantastic panel today, and I'll be introducing them very shortly. Some housekeeping first. Your microphones are muted. We've got, we believe, over 1,000 people or over 1,000 people registered. So it's going to be very difficult to have everyone unmuted. Please use the question and answer function at the bottom of your screen to submit any questions or comments. Please try not use the chat function. Keep it, please, to the Q&A function. It'll make it easier for us to identify the questions and comments and to respond to them. We're going to try our best to respond to all the questions and comments. If we're unable to get to all of them, we do follow up with responses to the whole group that you can then download. So at the end of the session, which is being recorded, you'll all receive an email with copies, with a link to that recording in a day or two, and along with it would be a comment about the response to the questions and answers. So I'm Dr. José Pereira. I'm Professor and Director at the Division of Palliative Care in the Department of Family Medicine at McMaster University, and I'm also Scientific Officer of Pallium Canada. Our moderator today is Dr. David Henderson. David, could you introduce yourself, please?
Hi, yeah, Dave Henderson. I'm the Senior Medical Director for Palliative Care in Nova Scotia. Yeah, so we've got a kind of broad country perspective that we will be delivering today. So for our panelists, we have Naheed Dosani, who will give his background a little bit further. Rob Horton, Dr. Denise Marshall, and Dr. Ron Spice. And as I said, we've got kind of a cross-country look at things going from East Coast to Nova Scotia, Ontario, and out west in Calgary. So yeah, we'll go on to our next slide.
Pallium Canada is a not-profit organization. We would really want to thank Boehringer Ingelheim, who've done fantastic support of this webinar series, allowed us to get it across the country. We also want to acknowledge the support from Health Canada, who's also over the years and currently also funding some of the palliative care work. In terms of declaration of conflicts, I'm paid by Pallium Canada as Scientific Officer, and I don't believe any of the other panelists have got any conflicts of interest to declare. At the end of this webinar, we're hoping that you're able to use best available evidence and, importantly, experience to inform the optimal use of virtual care, to understand the strengths and limitations of virtual care, to leverage its strengths and to mitigate its limitations, and we'll be hearing the insights from our panelist group. There is already a body of evidence, and this is a slide that Naheed had created, And if you do a search, you'll find references coming from projects in different countries. Today, we're fortunate actually to have two of the groups represented in our panel. So we'll be hearing about the experience from Alberta, from Dr. Ron Spice, who will introduce himself when his turn comes up. And we'll also be hearing from Dr. Rob Horton, who will also introduce himself when his turn comes up.
I'll introduce myself now. I'm Rob Horton, palliative care physician at Dalhousie University in Halifax. And just to set the stage around definitions for telehealth and telemedicine so that everyone's clear what we're talking about. Specifically, we're talking about telecommunication technologies to provide medical information and services without seeing the patient. So that can include video, which is what we're going to spend the bulk of our time probably discussing today, but also include things like email, telephone follow-up programs, real-time dashboards and text messaging. And telepalliative care is the remote delivery of palliative care services and clinical information using any of those modalities. I think what most people have tuned in for today is probably for some insights around how to best provide real-time video visits with patients and their families. So I expect that's a lot of what we'll be talking about today.
All right, so we're going to start with Denise Marshall talking about some experiences. Denise?
Thanks, Dave. Yes, I'm Dr. Denise Marshall. I'm a palliative care physician working in the Niagara region of Ontario. And I have I guess you call it a population-based team, meaning we cross all care settings, serving our local hospital, hospice, house calls, long-term care, kind of any setting of care. And I am on this panel and grateful to be here as the newbie to using virtual care since COVID-19 started. So I'm just telling you a little bit about my experience. I, like many people I'm sure on the phone, registered in Ontario. I registered with the Ontario Telehealth Network a couple of years ago, especially when they opened this up to palliative care physicians, and got everything all organized and then didn't use it. So I started using this really for the first time at the beginning of COVID. I think it was the third week in March. And so I'm sharing with you my experience to date. I've used mostly that platform, the Ontario Telehealth Network platform, but I've also used FaceTime, and I've tried to follow provincially the platforms our Ministry of Health has said are their preferred or more secure ones. But if I'm just speaking to what I'm doing right now, it's been mostly the OTN platform and FaceTime. And then third, as we just heard, is my default is phone. So what can I currently share with you? Well, 100% of my house calls right now for that sector are being done virtually. And so we went from 0 to 100%. So that means all my initial consults and all my follow-up visits. My team has myself as the medical director. I have another physician working on my team and a clinical nurse specialist. And we all moved to this at that time. It's been a learning curve, and so I'm pleased to be journeying with you on this. And I want to tell you a few of my current issues. One is, and we'll hear more from the other speakers, is that I started to do this in my team, parachuting in without this being part of our regional or local system of care. So we don't have partnerships with home care. We don't have partnerships with nursing agencies to be able to access our nursing colleagues and their platforms in the home. We're literally parachuting in and doing our palliative care consultation on our own. It's been difficult then to have a learning curve to either try to line up having a nurse visit in the home and at least assist in the home, or doing it without any care provider there other than us palliative care physicians. For sure, I share with many people, I think, here the advantages I found that were surprising so far. There is a real sense of connection that I've enjoying. And it's not true that across the board you lose a sense of intimacy. It's been quite sweet, actually, to be doing this with consumers. So there's parts that I enjoy that way. The parts that I don't enjoy are the fact that it's a rapid learning curve for everyone, including consumers. They don't have their platforms ready. This hasn't been socialized and normalized across their care community before this. People have difficulty sometimes downloading the part they need to use their computer or their phone to do this. Other times it's okay. But picture I'm doing this without having had the system roll out. And so that's been a bit of a limit. many times we just can't get it going with, we can't get another person in the home other than maybe an elderly patient and their partner, and we can't get the technology going, and we revert to a phone consult. So it's had highs and lows for sure that way. It's not ideal in many ways right now because we're doing it on the fly. But I'm learning a lot. And one of the things I've learned about this is I've automatically started to triage, you know, who am I most nervous about doing these house calls on, either for the consult or the follow-up, and why. And I guess I'll share with you, and this will inform my behavior after COVID, is I'm most nervous about people where I don't have a visual at all. For sure, the phone makes me most nervous. If I can't get a good handle of the actual medication they're ingesting, not what was prescribed, but what they're actually taking. So when I don't have another care provider in the home and I can't get the medication sorted out, certainly when it comes around to controlled medication, that's what makes me most nervous. I have found that I'm automatically thinking of triaging, and I've done a few house calls when I've had to, but it's when I've had to swab people for COVID. So I've got this list of when I can return to normal. What I want to keep going is using this platform for follow-up visits, not so much consults, with a care provider in the home wherever possible, like a visiting nurse, and having that set at the systems level. Triaging people who I'd need to go to see if it's based on needing to do the physical exam and needing to do a follow-up physical exam if I really feel that's a big deal. And so my first go-to is going to be gathering my system together to see if we can get the other component set so it's not an isolated palliative care team trying to do this without the other parts in place. For sure, I've already heard some rhetoric that this would be the new norm, and I don't feel it will be. I want to take the best of what I'm learning and the literature and what we're going to hear from these other colleagues on the line today and ensure that I carry forward now virtual care with some sort of video link is my new norm and practice, but that I don't become overly reliant on it across the board the way I am now. I feel I'm overly reliant without system support and not having the pieces in place. So I want to make sure locally we have really good discussions to move it forward for sure, but as part of a system of care from here on in. So I think I'll leave it at that for now and pass it back to you, Dave.
Thank you. I'll just jump in. There is one question. It says, do we know what the law says about using FaceTime and phones for patient care during COVID-19? And I think we'll probably touch on that a little bit as we go through. And I think one of the questions José was looking at was, within each province, does every province or any of the provinces have a significant or a distinct platform for all physicians to be able to use that has looked at all those safety issues and providing this type of care? So maybe we'll come to that as we go through the rest of the talk. We'll go now to Ron Spice from Calgary. Ron?
Thanks, Dave. So yeah, I just want to talk a little bit about the Calgary zone's perspective and the work that we've done over the last few years. So admittedly, the study that's on the screen, although published in 2019, relates to research that came out as a result of a grant from the Canadian Frailty Network and research that was done back in 2015. So pre-COVID, we realized that we needed to look at an online platform to connect with people in their homes. Next slide. So the area that we did this in is in Alberta, and the Calgary zone is a zone that goes about 100 kilometers in all directions from the city of Calgary. The main office of the Rural Palliative Care Consultation Team is in Okotoks, which is just south of Calgary, which is where I am right now. And we were finding a number of issues. We have a team similar to Denise's that provides care in a wide variety of locations. Anywhere that palliative care patients are, we will see them. And we obviously have a fairly large area where we might have to drive 100 kilometers in any direction to get to one of our patients. So challenging geography. Maybe go on to the next slide. And we had to look at what we were going to do from the standpoint of trying to meet the demands. Our patient consultation load was increasing. We had issues with barriers of time and distance, occasionally bad weather, large volumes of consults. There were days when obviously our 2 or 3 nurses and 2 or 3 physicians might be going in in 6 different directions. So we did our very best to provide face-to-face care, but we decided to look at a system of ongoing web-based video conferencing to connect with people. So we often would have a nurse specialist, an advanced practice nurse, who would visit the patient in the home, and then they would do a phone consult with the palliative consultant. And our web-based video conference was trying to make it so that that palliative consultant could have that face-to-face interaction with the patient as well. So the way we set up this study was to have the nurse specialist in the home. And that made it so the patient didn't have to worry about setting up the technology, setting up the laptop, making sure they knew how to use the platform. We almost always met with home care in the home as well. And then there would be a distant physician using what was then called Link, but is now Skype for Business. Next slide. So the next slide. So it was a small study. We had basically looked at interactions with 10 patients. We had a lot of family members that were involved with those. And we also had a lot of healthcare providers and our clinical nurse specialists. And we did surveys, and we did focus groups, and we interviewed patients and families. And overall, our results showed that the majority of people agreed or strongly agreed that the technology functioned reasonably well, that they would use web-based video conferencing in similar situations, that they could communicate effectively. It was an effective use of their time. Their needs were addressed, and they were comfortable. The next slide, that's the patient and family questionnaires, and the healthcare questionnaires followed a similar pattern of 80 to 90% agreeing or strongly agreeing that things worked pretty well, that they were comfortable, that issues were dealt with, and that they were fairly happy with the way the technology worked. We did a qualitative analysis as well and came up with 4 main themes of communication, logistics, trust, and technical issues. The qualitative results of the communication section were largely positive. People were quite happy with what they could discuss, what they felt comfortable discussing, and the way that the communication worked. Logistics was just around the actual setup and the length of time. We found our interactions were sometimes longer and more tiring for patients because it took a longer period of time to set up and troubleshoot. We had some issues of trust. Some of our participants were concerned about confidentiality, were concerned about whether the web-based video conference platform was safe, whether their medical information could be available to others. Even simple things like whether the person that they saw on their screen was absolutely who they said they were. Is that really Dr. Spice? Sort of. So we found that just like in the hospital, it was important to identify ourselves, to perhaps have a placard with our name on it, to make it pretty clear that they are talking to who they think they're talking to. And finally, there were technical issues. Our web-based video conferencing was often done over a cell phone signal using an air card in a laptop. And lots of places in the area surrounding Calgary have very weak cell phone signals. We often couldn't rely on the patient's Wi-Fi if they didn't have Wi-Fi, or if their Wi-Fi wasn't very functional. So we had glitchy situations where audio froze and video froze. Sometimes we had to click off the video because the bandwidth was too much. We went on to a second phase of this study. Actually, I'll deal with the conclusions of the first study. Was that by and large people were accepting. We had audiovisual quality issues, obviously reduced a lot of travel and the burden of travel for either the patient or the providers. It reduced the burden of travel for patients having to go to a video conference room in a hospital or a facility because they could do it from their home. It enabled real-time home discussion because we had the benefit of having home care, family, patient, consultant, and clinical nurse specialist all involved in the same video call almost all the time. We found that it was better than a phone call, but obviously not as good as an in-person visit. In our second phase, it was very similar to the first phase, except we skipped the middleman. Rather than having a clinical nurse specialist in the home, we allowed home care to connect with us directly. So home care would identify a patient that might benefit from a video visit, and either the day before or the day of, they would say, are you available for a video visit at 2 o'clock this afternoon? And so quite quickly, we would have that connection. And it worked quite well. I think there are the results of phase 2 were very similar. Nothing surprising. People were quite happy with the way that the technology functioned. Those bars are for comfort and communication and whether needs were addressed and whether it was an effective way to provide information, effective use of time, and whether they would use it again, blue being strongly agree and orange being agree. So similar results in phase 2. The only thing I would say, similar to Denise, is that we have come to understand that it's a good platform, but the areas that we were most concerned about is we didn't want to become so available by video conferencing that we got in the way of the primary care relationship. We don't want to be more available by video conference than the family doctor is by other means. So we wanted to stay in our consulting role. We wanted to stay as helpers rather than we're here, call us anytime, here's my number. So we wanted to make sure that our service was helping rather than using video conference to actually take over a relationship that we believe is most strong between the family doctor and the local home care people. So I think I'll end there. Thank you.
So I'll go ahead and jump in. Thanks very much, Ron. I think around the same time Ron was moving forward with his efforts in Calgary, 2016, 2017, we were engaged in similar efforts here to try and support some of our more outlying centers in between regularly scheduled visits. So at the time that we launched our program, there was no mobile telehealth network in Nova Scotia. There was an institution-based, hub-based telehealth network where patients could travel to access telehealth, but that really wasn't feasible for the majority of patients that we were following in the Hants Community Hospital. So Windsor, Nova Scotia, for those of you who aren't familiar, is about an hour outside of Halifax. It's predominantly a rural population. They've been resourced with a palliative care resource nurse consultant for about the last 15 years, and she does most of the primary consultative work and collaboration with family doctors, hospitalists, and local VON and home care nurses. But she's additionally supported every 2 weeks we would go down, one of the palliative care physicians would go down to provide support through outreach clinics. So on any given day in a trip to Windsor, we would see people in the hospital, people in the outpatient ambulatory care clinic, and then tag on 3 or 4 house calls towards the end of the day, on a busy day, and on a quiet day, 1 or 2. And what we found was that it wasn't uncommon in between our bi-monthly visits that people would have significant changes in their status. And much like Ron was saying, typically those would be dealt with on the phone, providing some stopgap measurement until the next time one of us happened to be in Windsor to do some follow-up. And that often did meet people's needs, but we started to wonder whether or not we might be able to effectively use more mobile means of telehealth to provide more of a real-time access to a palliative care physician, provide some reassurance to the patients and their families, and as well support the resource nurse, who really, compared to many of the other resource nurses, was often out on her own without a lot of backup. So we decided to kind of launch this project. It was done with the assistance of a first-year medical student who signed on to a research in medicine program where you would develop a longitudinal research program over a few years. And as I said, at that time, we didn't have a lot of infrastructure support through the health authority to offer IT support. So we kind of did this off the side of our desk using iPad and FaceTime and exclusively over a cellular data network. So one of the issues in Nova Scotia, like in many parts of Canada, is that access to broadband, particularly Wi-Fi services, is not particularly reliable. And so we were wondering, well, how feasible is this? Can we really deliver this kind of care over a cellular data network? And so we're really interested in a proof of concept. is this something that is technically feasible? Is this something that patients and their families would accept and that they found useful? And then if so, what ways could we look at taking what we learn and maybe generalizing it to other aspects of our program? So we enrolled 15 patients in a 6-month period between January and June of 2017. And I want to point out that all of these patients were all follow-up visits. So these were not first-time consults. There were people that were seen for an initial assessment in person, usually in an ambulatory clinic setting or at home, and then offered the opportunity to enroll. And then we would see them again by telehealth on an ad hoc basis when there was a change in their status that required some kind of change in care plan or reassessment. And so the thing I want to point out as well is that this was a one-time intervention. So we would do the intervention with the patient over iPad. The nurse would go and visit the patient with her own iPad, pull up the link, get everything ready. So from a technical perspective, the patients didn't have to worry about what link do I click on, or do I have the right equipment? And then we would have the consult. As per normal, we would generate or dictate a consult note to the patient's primary care practitioner, and then arrange follow-up either through an in-person visit the next time we were in the area, or offer follow-up by video if that was something the patients wanted. And then we asked them to rate their experience within 24 hours by survey and return the survey by mail. So really what they weren't rating a longitudinal experience, it was a one-time intervention. And the things we wanted to know were, first of all, was this feasible from a technical perspective? So we asked them to rate the quality, much like Ron's study, rate the quality of the audio and the video and the internet connection from 1 being terrible to 5 being very good and 3 being neutral. And then we also asked them to rate their overall satisfaction with the experience. So their overall satisfaction, whether they felt their medical concerns were adequately addressed, and again, whether they were willing to use it in the future. And we set a feasibility limit or criteria for 70% of people responding either positively or very positively. So if the response was neutral or less, that didn't meet our feasibility criteria. If 70% of people were responding positively or very positively, then that was deemed to be feasible from a technical perspective and from an acceptability perspective. So what we found was that, very much like Ron's experience, there were some technical glitches. It wasn't always perfectly smooth, but despite that, the reports from patients were pretty positive. We had 14 of 15 surveys returned. 100% of the return surveys reported either 4 or 5 out of 5 video and audio quality. We didn't have to terminate any consultations because of technical problems, but we did have some problems with freeze frame and video stuttering and a couple of drop calls that we were able to quickly reestablish. One of the benefits of FaceTime, of course, is you can quickly just redial and get somebody back. Might not be as easy to do with some platforms like Zoom. So despite a couple of drop calls, all patients reported quite a positive experience and a willingness to use it again. And it actually went better than we thought. I was kind of anticipating a lot more technical glitches over a cellular network than we experienced. The LTE network in Nova Scotia, like in the rest of Canada, is a 4G network, and it was just coming online around that time when we were getting this up and rolling. And so it actually worked fairly well. I suspect the next iteration when we go 5G would be that much better. The other thing we looked at as more of a secondary outcome was, well, what are the benefits in terms of physician time and costs and travel time? So because we had the address of every patient, we would plug that into Google Maps, and you can pull up your round trip route, and it will give you the distance, and it will give you estimated travel time. So we actually plugged that into a bit of a spreadsheet to keep track of things. And what we found was that had we driven to see every one of these patients, we would have traveled over 1,900 kilometers just for 15 patients, and travel time over 24 hours of elapsed travel time. We did some rough cost estimates, assuming $150 an hour if you're working on the cheap, there's potential for significant cost savings in the range of $3,000 to $5,000 just within the small number of patients we saw. So, I think that's one of the big positives and efficiencies of this format. But I still think there's a lot of questions to be answered, and I think it was effective as a follow-up as a follow-up measure to follow up on people that you've already seen in person. Since the pandemic has come along, we've done a number now of initial assessments on the fly, and I will say it is more challenging. There's no doubt. I think we'll get into talking about some of those challenges in the discussion aspect of things. But our overall conclusion was that it was positive. There were some efficiencies to be gained, but that there's probably a lot more we need to do. So we were hoping to, if we go to the next slide, we were hoping to roll it out more widely across our program when the pandemic struck, and of course now everybody is using it by necessity rather than by design. But one of the big questions that's left to me is, and I think many people have asked, is okay, we know it's effective from a technical perspective and it's feasible and acceptable, but how does it compare to the standard of care of in-person visits and house calls? And there really isn't any data to guide us on that. But I just came across this the other day, which I'm very intrigued to see the results of. So this is a protocol that was in the Journal of Palliative Medicine recently. I think they're probably accruing patients now, and this is going to be a 20-center study that's going to randomize over 1,200 patients with lung cancer to either early stage integrated palliative care by telehealth or in person. And they're going to do real-time patient-centered outcomes on a quarterly basis running out to 48 weeks. So I think that would, and in addition to that, do some bereavement interviews with caregivers and have both qualitative and quantitative data. So I think that will go a long way to answering, is this something we can take and generalize in a broader way? I'm still a little bit reluctant, and like the rest of you, I mean, the thought of doing, I'm already Zoom fatigued from the amount of stuff just since COVID has come along. It is uniquely fatiguing in a way, and so I think there are some strategies that we have to look at to use the good things about this tool, but also realize it can't be the be all and end all. So that's all I have to say at the moment, but I'll chime in during some of the discussion session if people want to move on.
Greetings. Hi, everyone. My name is Naheed Dosani, and I'm a palliative care physician who wears a few hats. And one of my hats is working at the William Osler Health System in Brampton, Ontario, which serves the Central West LHIN, which includes Brampton, Caledon, and a large proportion of the region of Peel. Before I move forward, I do want to thank all of our frontline workers, PSWs, and it is Nurses Week next week, so we're so grateful for everything that you guys all do. We started this initiative in August of 2018 in a response to what patients and caregivers were saying to us, that they wanted to receive palliative care and they wanted to use technology. We offer a 6-pillar program at William Osler Health System, which includes acute palliative care unit, inpatient palliative medicine consult team, our outpatient ambulatory clinic, our community program, our hospice program, our structurally vulnerable and homeless program, and in addition, our latest addition, this virtual care program. The program was aimed at delivering timely palliative care access and did not include new consultations. So anybody who was in this program and enrolled in the program was basically already being supported through their family physician, but also through a primary palliative care MRP on our team. The clients in the program were actually recruited for various reasons. There may have been distance from the hospital, it may have been appointment fatigue, it may have been social determinants of health, or it may have been longer wait times around palliative care access. We did not include home and community care within the program, and these were seen as mostly outpatient follow-ups as it pertains to palliative care. From a logistics perspective, the program was done through the Ontario Telemedicine Network platform. We had the Ontario Telemedicine Network supporting the program with real-time nursing support, as well as IT support at the same time. We were conducting ESAS scores by telephone and through a pilot, which we won't get into too much here, using an app called the Relief app, all in the spirit of getting people online. As we move to the next slide, We did complete a retrospective chart review, reviewing our patients over a 6-month period, and we reviewed 61 of the clients that we cared for. And we found that the average age was 71.7. We have a gender breakdown there. Our primary palliative care diagnosis was by and large malignancy, but we did have the potential to care for people who also had a variety of other conditions like neurodegenerative conditions, frailty, heart failure, or COPD, for example. And we did find that we were caring for a very sick population during this program, where the average comorbidity, when you looked at the number of diseases that people had, average comorbidities ranged at around 4.65 per patient in the program. A little bit about demographics. I've touched on this a little bit. The reason for referral to the program was first around symptom burden. That was the #1 reason. The second was actually social determinants of health, and this had to do with costs associated with parking, taking time off work, caregiver time off work, which is often not information that we're tabulating in our day-to-day, but definitely the people we cared for spoke to about that. Caregiver burnout, distance, and longer wait times for access to care was also a reason for referral. We cared for people who did not want CPR in the event of a cardiopulmonary arrest, but also people who were actively, who did actively want CPR. And 75% of the time in cases where people passed away, they died in their preferred location of death, whether that was home or hospice. And in terms of devices used, we found that 83% of the time people were using smart, either phones or tablets, and 17% of the time they were using computers. We completed a total of 227 virtual visits. We offered 2 virtual care days per month, and the average, on average, from a patient perspective, patients received 3.7 virtual visits per patient. Remember, this was a point in time, and we followed people throughout that point in time. We did not stop people from having in-person visits, and so people did come into the palliative care clinic or get physical home visits if they were needed. Examples included if people needed intervention, like a POCUS-driven, POCUS-guided paracentesis. Well, it's hard to do that through virtual care as of 2020, so we did bring people into the clinic. Or if people had very difficult to manage symptoms, we did ask for an urgent home care, palliative care follow-up visit, but it didn't happen often for people who were in the program, but it was nice that they had access. We thought that continuity in the program was important, and we found that the percentage of people who completed more than 3 virtual visits and required no hospital admissions at the same time was 82% in the program. So we're really excited about the potential results here. Not everything was perfect. We did have some incomplete visits, and that's important to talk about as well. Of those incomplete visits, we found that about half were related to technical issues, mostly related to the Ontario Telemedicine Network apps on the smart devices, but I can talk more about that. In other cases, it was more about miscommunications around appointments or erroneous bookings. We can talk about that as well. But basically, if you take all of our visits into account, of the attempted virtual visits that were incomplete due to technical issues, it was only 6%. So what did we do in these visits? And looking back and through this retrospective chart review that we're really excited to share, we recently shared this data at the Hospice Palliative Care Ontario conference and are looking to submit for publication now. We found that 84% of people were requiring psychosocial support. Education was a big part of it. Review of medications was a big part of it. Referral to other services, discussions around goals of care, or even ordering investigations like blood work or diagnostic imaging, for example. And so these were kind of the foci of the visits particularly. So lessons learned through the William Osler Health System virtual palliative medicine program include the fact that virtual care is possible in a community within a larger tertiary driven palliative care program and can deliver aspects of primary palliative care at the same time. That there wasn't a lot of learning required for patients and caregivers to be participants and receive coordinated care. We recognize the importance of communication. There was initially, there may have been some skepticism on part of some of the people that we were caring for, but that we did note overall that people were very excited about the technology and participated in care once they were in the program and mostly did not want to leave the program. So as we move into part 2 of the presentation, it's fine and dandy to hear about experiences from little pockets across the country, but it's important for us to reflect on how we may feel at the end of this presentation and how we want to move forward in our community so we can derive opportunities for virtual palliative care in our community. So what we've done together as a team is come up with 10 practical top tips for developing virtual palliative care in our communities. And what we'll do is we'll move into number 1. And so this is more around the actual logistics of when you're actually providing virtual palliative care, you know, thinking about your environment and setting up in a quiet space with good lighting is important. Thinking about your Wi-Fi network and connection is important. Having a camera with high resolution is important. I still, when I'm doing virtual visits, will wear my hospital ID so people can understand that, like, I do work for, you know, the hospital, and so people understand who I am. We, at the William Osler Health System pilot, we actually had a script that we read people the first time we saw them. And so that script included a comprehensive introduction of ourselves, the role in the program, and how the program works. So really setting the environment is really important at the outset. I'm looking to my other panelists for any other insights as well. Okay, feel free to jump in. Number 2, keep it simple. We appreciate that this is a national conversation, and then depending where you're tuning in from, you may have a platform that you might have to use, or you're using for a short time due to the pandemic. Regardless of what it is, you'd want to make this seamless on the patient's side. We found that by calling ahead before the visit and actually walking through a test of the use of the platform, reduce the technical or abandoned or missed appointment show rate when we actually got there. So we find that the platform is really important as well. Number 3, be familiar with security and privacy details. Of course, you want to be using technology that's secure. And during the pandemic, we are recognizing that many ministries of health across the country have said to practitioners, look, as long as you get some sort of verbal statement or a signed statement of some sort, depending on where you are, you can use FaceTime or other technologies. Privacy is important, and I found that we find that when you start the visit by talking about security and privacy and how people's health information is secure, that rarely becomes an issue as you go through the experiences with people you care for virtually, but it's really important to talk about at the outset. The other thing to mention is just to mention that you're not in a coffee shop somewhere. Probably shouldn't be in a coffee shop nowadays, but if you're doing virtual care, just so that you're in a private location and that when you speak, people can't hear you. Number 4 is be transparent. I think there needs to be a clear recognition of virtual care's limitations. I don't think any of the speakers on this panel are standing here to say that virtual care is now replacing all of palliative care delivery moving forward. That's not what we're saying. But what we are saying in different ways and shapes and flavors is that virtual palliative care probably is a useful adjunct in our delivery of care, not just during a pandemic, but probably after the pandemic as well. So when it comes to physical examinations, for example, I do let people know that this sounds like an issue that requires intervention or physical exam. And so in-person visits are also really needed as well. And I feel like that image in the bottom really captures that issue. Number 5, engage caregivers near and far. One of the neat things about many of the platforms that we've talked about, and in my world, the Ontario Telemedicine Network, is the ability to actually bring in other people. And one of the things that we learned when we did our retrospective chart review is we had many cases where we had the patient living in the region of Peel in Ontario, but then the aunt was in Vancouver and the uncle was in Jamaica and the cousin was in Germany. And if you got the timing right, you can actually get them all on the visit together to talk about any issue that is driven to support the patient that we're caring for, but also talk about goals of care conversations and even helping people walk through various decisions like their goals of care around who makes decisions for them if they're unable to speak for themselves. And so leveraging, you could do this by telephone. I think with the visuals, we actually were able to make people who were afar feel like they were part of the circle of care if they were supposed to be. And so leveraging that as an opportunity is really important as well. And number 6 is finding the right fit. It's not virtual care in general, and virtual palliative care. It's not for every patient, and it's not for every caregiver. And what I do ask is that we think about the people that we're caring for, think about your region, the population you serve. And what we did is we came up with a list of questions that we asked people when we were recruiting them to the program. And if the gist was that people were not jiving with using technology, being online, then we said, you know, we'd love to have you, but maybe this isn't for you. And so developing those sort of guiding principles of what this is about and some criteria will allow you to pick the right people for a program like this. And if you pick the right people for a program like this and it fits, it's more likely to be successful. I do want to recognize that there is a concern around a social gradient when doing interventions like this, that people from higher socioeconomic brackets may have more access to care. And that is something that we realistically need to think about. And in some communities, we've seen drives where people are actually raising, getting support and donations for tablets and phones. And this has been really, really helpful. Number 7. Teamwork makes the dream work. You can't do this yourself. We realize people come from different backgrounds and come from different practice styles, and it may make sense to form partnerships and collaborations with people who can work together to make things successful for you. For example, it may make sense to team up with your home and community care colleagues to deliver care. It may make sense for primary care providers to work in a network to make this work. I knew that leveraging partnerships with our IT team, partnerships with our OTN nursing team and our palliative care team was really important moving forward, and that allowed us to have seamless execution as we move forward. Number 8 is leveraging community supports. So when you are running a virtual care program, it is important not to develop a virtual care program in a silo. And one of the unfortunate things about driving innovation is sometimes you just have to do things to show that they work. And one of the things that we were really frustrated with is that our nursing colleagues or colleagues in home and community care were not able to participate in the care because they weren't signed up as part of being a part of our virtual care program. And so it was really important to think about that, and moving forward, this program will start to unravel. We look forward to actually signing up members of our home and community care team, so our care coordinators, our nurses, so that, and even our PSWs who can actually join these visits and actually be part of these joint visits. When you start to take some of the work outside of the hospital, for example, outside of a clinic, then you need to know what labs and diagnostics are around as well. So you need to know your community, basically. Number 9, so it's not just for rural and remote. And I think that when people think virtual care, this has been the storyline for a long time. And I appreciate that we've had a wealth of research in this country around virtual care and virtual palliative care, which has made this very popular. And I think we get it, that rurality is huge. But through our pilot at the William Osler Health System, we have found that actually virtual care has been very important to support people with the social determinants of health. Parking costs, time off work, caregiver time off work has all taken a toll during people's disease journeys. And many of the people that we cared for saw virtual care as an excellent and important tool to alleviate their financial burdens, frankly, during a very difficult time. So thinking about those as alternative pathways to why someone would want to engage in virtual palliative care. And finally, number 10, that virtual care is really just an important part of any system's response to crises, like a pandemic, for example. And one of the reasons that webinars like this are so important is that we probably haven't planned for a virtual care network, let alone a virtual palliative care network coast to coast that supports people. And so when we dealt with stress, like a pandemic, we're now seeing a patchwork, make work development of systems. And I'm so glad that Pallium is putting this on together for us to be together so that we can actually share our experiences to have a better response. One has to wonder about the future and to think about virtual palliative care as part of our planning in each of our provinces and nationally, so that when there are system stresses like a pandemic, we can respond in a coordinated way. So virtual care is just a really important part of our healthcare system and any planning that is associated with it moving forward. And that rounds out the top 10. I feel like David Letterman over here.
Well done. This has been a great group, and we have time for some questions now. And I just want to share with everybody that these folks were on to pretty much to the minute for being on time. So well done. So we have questions, and actually even with the panelists, if you want to open up your Q&A section, and if you see specific questions that you would like to address, then certainly just please chime in.
David, it's José, and I was monitoring the questions and answers, and I've got a few of the questions that I summarized here quickly, and maybe Robert and Denise, if you could get started with this one, and that is, so when should virtual care not be done? When should in-person happen? And then after that, if Ron, if you could respond to a question about during the COVID time, have you found that platforms like Skype or Zoom have been able to replace or address the barriers you had previously experienced? And then also related to that is any use of virtual peripherals like stethoscopes. So first to Rob and Denise about what you think it shouldn't be, when it shouldn't be used.
Yeah, so
You want to start, Rob?
Yeah, sure, I'll start. I mean, I think there's a number of circumstances where it can prove challenging, you know, particularly if the patient isn't well known and things are changing quickly, or there's a new, you know, acutely evolving symptom that you're not going to be able to sort out with simply inspecting the patient visually, that you'll need to physically examine someone. That's one situation, but there are a number of others as well. You know, I think if you get a sense that somebody has significant cognitive impairments, even hearing and speech problems, it can be done. And even, you know, we can get translators through Zoom here in Nova Scotia, but it does make it that much more difficult. And those are situations where you might want to consider whether you can do an in-person visit. Last week, I can give an example. I did a first-time assessment in a woman who'd had a total rhinectomy related to a nasopharyngeal carcinoma. And so she had quite a significant dysphonia, and we were able to get through the consult. We actually had quite a nice interaction together and a few laughs even, but it was challenging. And I think it would have been better had we seen her in person. And maybe Denise, I'll throw it over to you to add in your comments.
Yeah, I mean, I only have the 8 weeks of experience, but so far I would say where I'm going forward, I say it doesn't work is when I just don't have any other healthcare eyes or ears in the home. And right now I'm finding that people don't want to have the home care nurse in, or the home care nurse will be calling in themselves. So when there's really no one else, when the partner is a frail elderly person who can't describe well what's happening, if I don't have a good visual look at people, again, it's that. I did a initial consult this week where it's an elderly couple and they have a landline and there's no nurse going in because they don't want the nurse to go in, even though the nurse is calling. And I just feel like I had great difficulty feeling I had a good handle on it. Things for me, like just eyeballing people sometimes helps me so much with prognostication, like knowing their functional status. So I just, you know, echo what you've said, Robin, would add that. If the landline is all we have, and I'm trying to do my entire palliative care consult from a distance without ever laying eyes on, that doesn't feel good to me.
Yeah, I think if I could add one more point, one of the things that Naheed mentioned in his top 10 tips was that, you know, involving family caregivers. I know a lot of times they've been really valuable tech support for some elderly parents who might be having some issues unmuting their microphone or getting connected, and so they can serve both as, you know, family support, but also some much needed tech assistance when people are home, maybe without a healthcare provider in the home.
Great, well, thanks for that. The question around platform is an interesting one. When we did our study in Alberta, we used Skype for Business because it's loaded on every Alberta Health Services laptop, and we used the platform that was there. We used the platform that already had a privacy impact assessment done on it, and we used that platform because we knew we would be taking either the home care nurse or one of our staff would be taking that laptop to somebody's home. Since COVID, most of our interactions with patients are happening using Zoom, and Zoom seems to be a bit more user-friendly. It seems to use a little bit less bandwidth, so it's a bit less glitchy. And it seems to be easier for people to connect multiple people from different places. And of course, in Zoom, the family may be in one place, and the patient's in another, and the doctor is in another, and the nurse consultant might be in another, and the home care nurse may or may not be involved. Because we're having the same issue that you're having, Denise, where sometimes our home care nurses, with having to use PPE and all the other things, they can see a fraction of the patients they used to be able to see. They just can't be everywhere at once. So Zoom has become more helpful, but it has made it less easy for us to involve different members of the team. You know, in a perfect world, the family doctor might be on that Zoom call, and the home care nurse might be on that Zoom call, and same with the family. And we would actually have everybody on the same page in the course of a half an hour or an hour. And that's harder to do right now. There was a question about peripherals. I had high hopes for peripherals. I had high hopes for electronic stethoscopes. What we need is an electronic stethoscope that is absolutely simple, that basically is like a microphone, except it's a stethoscope. You plug it into your computer, you put it on somebody's chest, and it works. And unfortunately, a lot of the manufacturers that make electronic or digital stethoscopes, they put so many features in them that you can adjust whether it's low end or high end or pitch or frequency and loudness, and it's just, they're hard to use. Something simple that was just like a microphone that you plug in and put on the patient's chest would be great. But I haven't been able, they do exist, but I haven't tested them. There are one or two that are simply, you know, an 1/8 inch or whatever, a 3mm jack, you plug it in and it works. So we need to test them because we may be doing this for a while.
I see a couple questions here. One was, why was home and community care included? I think that speaks to the importance of the fact that in a virtual palliative care program in isolation could be very difficult to actually provide that holistic kind of care. And in the absence of, for example, like wearables that we're talking about, peripherals, which allow us to do physical exams with people through technology, we really trust our home and community care nursing colleagues, for example, and PSW colleagues who are physically having contact with people in the home. There's a question from Jing about the Relief app. Yeah, so a bit, just a quick note about this. To couple with this intervention, we have currently the standard is that people experience symptoms and then they call, you know, their nurse, or for example, to have a visit, and then they might call the on-call person to prescribe medicines to manage symptoms. What if you had an app where you were reporting your ESAS score and there was an AI algorithm that was measuring the changes in the ESAS scores and called you before you actually had to call someone else? And that's what the Relief app essentially is. And we've piloted it on a group of 30 patients in the community at Osler Health System, and look forward to rolling that out in Ontario and across Canada soon. But that was what the Relief app was.
There's one question there. Someone asked about any financial incentives for the public to be able to actually get some of the equipment to be able to allow this to happen in home. And I know for Nova Scotia, I'm not aware of any. I don't know if anybody wants to speak from their other provinces.
Not that I'm aware of, but a ring light costs like $25, and you know, webcams are usually installed in most computers. So this technology has not been expensive. I'll just make a comment around that. And
I guess I'm wondering, just for, I'd say it'd be rare these days that people don't have a computer, but there may be certainly some people without. And maybe I'll ask one question as well too, really kind of looking at the rural areas. I know in Nova Scotia, we've got areas that don't have access to high-speed internet. So then you think about using your device as a hotspot, just about quality of sound and video and such. I don't know if anybody's had experience with that.
I can speak a little bit to that. I mean, we did have some consults when we were doing the study over the cellular network where there'd be, you know, momentary fragmenting of the sound or freezing of the video, but it was only a minority of the times. And these were locations where there wouldn't typically be good wired access to broadband, but seemed to be adequately covered by the LTE network, at least enough to get through a console. One of the other things I found was that some people have mentioned that often the the visits seem longer. I found for some of the follow-up visits, actually, they might even be typically shorter than what you might expect if you were seeing the patient in person. By the time they get in a room, take off their clothes and get settled in. And so there were times actually it was more efficient if you knew the patient, what the issues were, you were following up on one or two issues. It all depends how complex the situation is as to how easy that is to do over the internet.
So we were down to about our last minute. Just a comment from Ian Senara in Calgary that there's a Zoom for Healthcare version that meets the PIA PIPA standards for approval for clinicians interacting time. And I know that's what Alberta is using and Nova Scotia is using as well.
My understanding on the whole HIPAA issue is sometimes it's hard to track down, particularly FaceTime. I was trying to track down, is FaceTime HIPAA compliant? And I've done a bit of research around the issue, and it seems from a technical perspective it actually is, but the reason that it's deemed not to be is because Apple wouldn't sign a health services agreement with Health and Human Services in the US. But from a technical perspective, my understanding is that Zoom for Healthcare, Skype, and FaceTime really all meet the specifications.
Okay, thank you, Jose. Do you want to close us off?
Sure. Thanks to all of you. Thank you so much, Denise, Naheed, Dave, Ron, and Rob, for your insights. There was a flurry of activity in the question and answers and comments section that makes me think we need a follow-up webinar on this topic. Some fantastic comments, fantastic questions. And please, to those of you who haven't responded yet, if you're in a different province that hasn't been mentioned here, so Ontario, we know there's a platform. Nova Scotia, there's a platform put on by the ministry. Alberta, if you're in another province and aware of a platform, please just share with us on the question and answers which province that is and what the platform is. This has been recorded, so some of you are wondering, you may have missed the beginning of it. It will be recorded. It has been recorded and will be made available within a day or two. You'll be getting an email on that. So look up www.pallium.ca, our website, and there's a link there towards resources. There's a link to the webinars with all the recordings of the previous webinars and this one as well. Please share it with your friends and colleagues. And again, to all of you, thank you for joining from across the country and even from different countries, from the US and from other countries. We understand there are quite a few people also linked from across the pond. So to all of you, thank you so much. Please stay safe and continue the fantastic work that everyone is doing across the country. Thank you and bye-bye.
Bye.
Bye.